Now, our next speaker, Professor Professor Rantij Akulikar. He is previously introduced. He will talk about vasa previa. Is it a condition worthwhile to screen? Please, Dr. Akulikar.
Yeah, so good afternoon. I will briefly mention about this condition called vasa previa. How many of you have managed pregnancies with vasa previa in your clinical practice? Can you raise your hands? How many of you have? Yeah. Correct. Yeah. So very few, very rare. Understand. So of course, this is why I mentioned in the title, is it a condition that is worthwhile to screen? If it is happening 1 in 20 years, is it something that I should waste 20 minutes talking about it and you should waste 20 minutes listening about it if you are going to see that if you are lucky once in 20 years, is the question. And is it an important condition to waste our time talking about? We discussed about the screening for prevention of stillbirths and how important is vasa previa in the aspect of stillbirth. And I showed this slide in the morning. And an important aspect of fetal hypoxia is vasa previa. And how is that? And as I mentioned in the morning, there are two kinds of fetal hypoxia. So fetuses will die. They don't die because of random reasons. Yes, when we have said that it is an unexplained death, it means that you and I cannot explain it, but there is a reason. And in many of those unexplained deaths, if you were to investigate and examine the fetus properly, a lot of your unexplained deaths would become explained. When you talk about hypoxia, I mentioned earlier on, and it is important to reiterate that there are two kinds of hypoxia. And hypoxia is just low partial pressure of oxygen in the fetal blood. So either you can have a chronic hypoxia where over several weeks and months there is gradual reduction of partial pressure of oxygen in the fetal blood, and the fetal responses to that reduced oxygenation reflected in growth restriction oligohydramnios abnormal Dopplers, or you have an acute hypoxia where you are perfectly normal today and dead tomorrow. And again, that is vasa previa. And when people talk about vasa previa, they sometimes get confused, but sorry, what is the issue? What is the issue with vasa previa? We all see placenta previa. Women bleed sometimes 200 ml, sometimes 500 ml, sometimes a liter, and they are all fine. The difference between placenta previa and vasa previa bleeding is that when you have a bleeding from a woman who has placenta previa, what you're losing is maternal blood. It is not fetal blood. You're losing maternal blood. The maternal blood volume after about 12, 16, 18 weeks of pregnancy is 6.5 liters. So out of 6.5 liters, if you lose 500 ml or a liter, she can still compensate and she will still be all right. She will be anxious, she will be worried because she has lost that much of blood, but she will be okay. When you talk about vasa previa, the fetal blood volume in the third trimester is 300 ml. And if you lose 100 ml of blood, which is half of a pad, that baby has lost half of its blood volume, and that baby is either going to have severe hypoxia, HIE, or will be dead. So even though you have a small amount of blood that is lost in vasa previa, that for a clinician, you will look at the pad and think, but okay, this is not much bleeding, don't worry about it. But that blood will exsanguinate that baby. So that is the difference between vasa previa and placenta previa. From a clinical perspective, all you are seeing is vaginal bleeding. But the cause of that vaginal bleeding is important. And as I mentioned earlier, it is important that when you see a fetus on a scan, it is important to change your attitude and understanding about how to examine the pregnancy. As we discussed in the panel discussion earlier on, there is a disengagement between what the parents want and what we want to do. Yes, we want to screen for aneuploidies. Yes, we want to screen for fetal anatomy for effective identification of birth defects. All the parents want is to go home with a healthy baby. So there is no point in me doing a perfect scan for fetal anatomy with a beautiful view of the corpus callosum and a perfect view of the pulmonary veins and examine the baby, do the NIPT testing and do whichever sequencing I want to do, but forget to do uterine artery Dopplers or forget to check the cord insertion and forget and rule out and ignore the fact that this baby has a filamentous cord insertion or an open cervix. I have missed the point completely, because that woman will have a 25-week delivery with a poor outcome, despite me doing the best anomaly scan in the world. So the point is not the anomaly scan, and therefore when we do ultrasound scans, it is important to assess what can be seen on an ultrasound scan. Fetal growth, fetal anatomy, important, but do not ignore the placenta, do not ignore the umbilical cord, do not ignore the cord insertion, and do not forget to examine the cervix. I will answer these 5 questions over the next few minutes. One is, what is vasa previa? Why should we screen for vasa previa? Who should be screened for vasa previa? Is it a selected group of people, or should everybody be screened for it? How should we screen for vasa previa, and what are the outcomes if you screen for vasa previa and if you have prenatal diagnosis? What is the outcome? So what is the definition of vasa previa? It is the presence of umbilical fetal vessels. Because fetal vessels in the umbilical cord are umbilical artery and an umbilical vein, and they are usually within the umbilical cord, protected by the Wharton's jelly. When you have a free fetal vessel which is unprotected by the Wharton's jelly, unprotected by the umbilical cord, lying freely in the amniotic membranes in front of the internal os of the cervix, that is known as vasa previa. It is literally a Latin word. Vasa means blood and previa means in front of. So vasa previa means blood vessels in front of. And in front of what? In front of the cervix. So that is the definition, number 1. Number 2 is, there are 2 kinds of vasa previa for majority of the practical relevance. When you look at the PubMed, when you look at the literature, people talk about a type 3 vasa previa, but ignore the type 3. 99% of the people in the world are not diagnosing the commonest type 1s and type 2s. So when you become an expert in diagnosing type 1 and type 2, then have an academic debate about the pros and cons of type 3. What is type 1? Type 1 is where you have a normal placenta, but instead of having a central cord insertion or an insertion of the umbilical cord on the placenta, you have an umbilical cord attachment onto the amniotic membranes, and therefore the umbilical artery and the umbilical vein have to travel through the membranes to the edge of the placenta and then to the maternofetal circulation back again. So when you have a filamentous cord insertion with vessels running between the filamentous cord and the edge of the placental disc with these membranes freely floating, that is type 1 vasa previa. Type 2 vasa previa is you have a normal placenta with a central cord insertion, and you have an accessory lobe or a sexcenturate lobe or a bilobed placenta, and you have a vessel that connects the 2 lobes of the placenta. Those are the 2 types. And this is how they look. On the left hand side is type 1. This is a type 1 vasa previa with a filamentous cord insertion, and on the right you have a bilobed placenta with a vessel that is connecting in front of the internal os. And this is just some images to help you to understand and visualize. This is a transvaginal scan of the cervix, and there is an umbilical artery from a filamentous cord insertion in front of the internal os of the cervix. Now if she was to dilate and the cervix was to open up, imagine the disruption of the amniotic membranes, and the shearing forces that will tear this umbilical artery apart will lead to bleeding. So of course that blood vessel needs to be diagnosed, because otherwise that blood vessel is at risk of damage. And this is a transabdominal view with a sagittal view in the lower segment. You have an anterior placenta and a posterior placenta with a gap in the middle, which is the bilobed placenta. If you put color Doppler on, you will find a vessel connecting them. Of course, all cases of vasa previa have to be confirmed with a transvaginal scan, and this is a transverse view. I don't want to show you just random images of ultrasound scans, because that is not the point. I mean, there are lots of beautiful images of ultrasound scans diagnosing vasa previa that we can show. But this is the real problem, that you have vessels running in the amniotic membranes in between the cervix and the baby, and if the amniotic membranes ruptured, all of these vessels get sheared. And when I said about the example of the 20-week anomaly scan with a perfect anatomy scan, with a perfect NIPT test, this is not me, this is the parents. If tomorrow you go to Google and write vasa previa, there are lots of newspaper articles. And these are people in England I'm sure that there will be cases in other parts of the world. These are people, some of whom who've had IVF pregnancies, some of whom who've had normal pregnancies, where they said, I had the perfect pregnancy with the perfect scan, perfect antenatal care, but that baby. And you have to ask yourself the question, what is the point? If the antenatal care and intrapartum care did not result in the birth of a healthy baby, there is a problem in our understanding as to what the parents want and what we are doing. And this is, you have to read, it is on Google, you have to read the parents' narrative. And the last one which is there, this is an acquaintance of mine. The couple who had this baby, the baby died sadly. The husband of this woman, they started a charity in England. That charity is known as vasaprevia.co.uk, and they campaigned for many years, and this is on the BBC website. And what they have written, this is the parents' verdict on what you and I do, that it was an avoidable tragedy, that it was so hard that it was, what they found most difficult was that it was an avoidable tragedy that could have been avoided. They are pushing the UK's National Screening Committee to make a 2-minute check of the placenta and the umbilical cord, a routine procedure at the 20-week scan. This is 2006. Today is 2025. Is the examination of the umbilical cord part of the routine anomaly scan? Of course not. We wanted to look at this whole situation of, is prenatal diagnosis of vasa previa helpful? So this is a topic of one of the PhDs of one of my students. So she has done a lot of work on vasa previa, and I'm sharing some of her work. So this is the evidence from every single study that did prenatal diagnosis of vasa previa over the last 20 years. Any paper published on PubMed with prenatal diagnosis of vasa previa, on the horizontal axis is the perinatal survival. And you can see that you have the forest plot that shows you the actual survival with the confidence intervals. And the answer is 99 to 100%. And the summary odds ratio is 98.7, which means that if you prenatally diagnose vasa previa, the survival is 99%. And then you have the same forest plot divided into two. On the top is those studies that compared the outcome in pregnancies with prenatal diagnosis versus those that did not have a prenatal diagnosis. If you do prenatal diagnosis, survival 98 to 99%. If you do not do prenatal diagnosis, the intact perinatal survival, which is survival without deaths or cerebral palsy, is 28%, which means 75% of babies in the absence of prenatal diagnosis will either die or will have cerebral palsy. I do not know of any other condition in obstetrics where our intervention in prenatal diagnosis will have an impact of life or death. You either have a baby that goes home and does whatever dreams, whether it is a investment banker or a doctor or a lawyer, to having cerebral palsy or death. There is very few conditions where our job and our intervention and our prenatal diagnosis will have the impact of night and day in terms of the perinatal outcome for that family. And this is the strategy for how to screen for it. This is all on PubMed. This is a free download paper from PubMed, so don't waste time taking pictures. This is all on Google. This just tells you that you have to document cord insertion at 12 weeks. Those that have a velamentous cord insertion and a low-lying placenta, if you don't have a policy of routine cervical length, at least do a cervical length on those with a velamentous cord insertion and those with a low-lying placenta. The prevalence of low-lying placenta at the 20-week scan is 10%. The prevalence of velamentous cord insertion is 0.3%, which means that you are doing a scan for 1 in 10 women. And if you did a scan for 1 in 10 women with color Doppler, you will pick up all of those with vasa previa. And this tells you, if you only screened IVF pregnancies, how many will you pick up? Because there are a lot of papers in the literature to say, okay, we have no money, let us only have selective screening, let us only screen the IVF pregnancies, let us only screen those with low-lying placenta. And this tells you the cumulative detection rate depending on which indication. If you did it for everyone with a low-lying placenta and velamentous cord, you will pick up almost 100% of pregnancies. I will mention about this issue of how common it is. Based exactly on the audience opinion from today, the UK National Screening Committee does not currently recommend screening for vasa previa. And this is on Google, this is on a public website. It says it is not a common condition. We do not know how common it is, and more research requires to be done, and so on and so forth. So more research needs to be created, but there is research. And what is that research? That research is, if you look at this paper, this is 100,000 pregnancies. It is not 5, 10, 50 people. It is 100,000 pregnancies in a systematic review and a meta-analysis that demonstrates survival of 99%. And second is what we did was to do that. This is how common is this condition. And the condition is common in 1 in 1200 pregnancies. The same incidence is trisomy 18. And if you compare the incidence of vasa previa to a lot of the conditions that you hear about in conferences all the time, on the left side is the incidence of how common is trisomy 18, then trisomy 13, then diaphragmatic hernia, tetralogy of Fallot, hypoplastic left heart, spina bifida, and vasa previa. This is comparative incidence of all of these conditions, and you are the audience, you are the judge, you tell me which is the condition where your and my intervention would change the outcome for that family, for that baby, forever. And how common is it? So if I had a limited pot of money, where would I spend my money? You tell me, you are the judge of that graph. And I will finish on these two things. So to summarize, what did I say today? What is vasa previa? Vasa previa is the presence of fetal umbilical vessels in front of the cervix. Why should we screen for vasa previa? Because if we don't screen for vasa previa, the risk of death increases by 25 times. The odds ratio for perinatal death is 25, and the odds ratio for HIE, grade 2 and 3, is 50. So if you don't diagnose it prenatally, your odds are for that pregnancy that is vasa previa, 25-fold increase in risk of perinatal death and 50-fold increase in risk of HIE. All women should be offered, and not just those with IVF pregnancies. Screen according to that flow chart, and if you do prenatal diagnosis, 99% survival. And this is just some take-home points with everything that we've discussed. So I'll stop there. Thank you.
Thank you very much for your nice presentation. Any question for Dr. Kolika? Please, Dr. Falah.
Okay. I understand that you have seen so many vasa previa diagnosed before delivery. But how many babies you have delivered where they have cord around the neck at the time of delivery? It's probably around 20-30% of any babies are delivered. Are we going to deliver them because we see during the antenatal care they have cord around the neck, then I go and deliver them? The other question, if you have a fixed, I understand if you have a fixed umbilical artery stuck to the cervix late in pregnancy, you will consider thinking of vasa previa, filamentous insertion of the cord and vasa previa. But most of the time, what you see a lot of cases where the cord crosses the cervix. Whether you do vaginal ultrasound or abdominal ultrasound, you will see it. Are we going to do cesarean section, and what time do we have to do it? Is it before they start laboring, or if they have rupture of brain, or, this is the question.
Yeah.
Are we going to prevent 1 in 10,000 or 9 in 10,000 pre-diagnosed? I don't know. It's just, I think it's very, very, doesn't fit. Yeah, it's fancy.
Yeah. So 3 questions you asked me. The first one was not related to vasa previa, but nuchal cord, and I will come back to that. The second question was that it is quite often that you see a velamentous cord insertion. So is it easier to spot the umbilical artery in the internal os, or is it easier to check for cord insertions? For those of you who do regular ultrasound scans, looking for the cord insertion at 12 weeks, we have time. We have done a study on 1,000 women, and we have put a timer on. How much time does it take to check the cord insertion? 32 seconds on an average during a 12-week scan, and about similar 38 seconds during the time of the 20-week scans. This is the time from when you close your eyes, open the probe, and say to the sonographer or the midwife, where is the cord insertion? 32 seconds. So and if you have a velamentous insertion, if it is in the upper segment, no problem. It is only if the cord insertion is near the internal os of the cervix, then you are at risk of vasa previa. If you diagnose vasa previa at 22 weeks, it is important, and I could not discuss it within the context of the time today, but because you've asked the question, 25% of vasa previas will resolve as the placenta previa resolves. If you have a low-lying placenta at 20 weeks, 10% of them, only only 10% of them will remain low-lying at 36 weeks. 90% will resolve. With vasa previa, if you have 100 people with vasa previa, 25% the cord insertion will move up and will no longer be near the internal loss of the cervix. So our protocol is that in our unit, the policy is if you diagnose vasa previa at 12 weeks, they go to a special clinic. We see them every 2 weeks to check the growth, to check the cervix, and to check the vessel. If the vasa previa resolves, we discharge them and they go to normal care. If the vasa previa is persistent, we do an elective cesarean section at 35 weeks because the chance of ruptured membranes, the chance of labor is higher after 35 weeks with a like-to-like survival at 35 as at 37. So we do an elective cesarean section at 35. So that is the last two questions. The first question was on the nuchal cord. There is no current policy of checking for the nuchal cord, but those of us who do obstetrics know that the presence of a nuchal cord at the time of delivery is 30%. The presence of a single loop of nuchal cord does not increase the risk of hypoxia, but there are papers that look at the fact where if you have 2 or more loops of the nuchal cord, that is associated with an adverse outcome. And we are at the moment doing a study. It is on the clinicaltrials.gov.uk, which is known as the U-loop study, where we are looking at the presence of nuchal cord at the 36-week scan and looking how many times it is present in labor and is it associated with cesarean section or any adverse outcomes. But I think 2 or more are important, 1 not so much.
Thank you. Any question? Dr. Abi.
Interesting lecture. My question will be, how can labor ward team be trained to act quickly in suspected cases of vasa previa?
I think that normally you're absolutely right. It is very difficult that if you have somebody arrive with antepartum hemorrhage, so the first thing is prenatal diagnosis. If somebody arrives to the labor ward and their hospital notes say that this is a known case of vasa previa, they have to go from the assessment room to theater, especially if they have vasa previa. The second thing is, in an emergency, you have to deliver the baby straight away. But in planned cesarean sections, even in planned ones, we do a preoperative ultrasound scan for surgical mapping. So this is a slight discussion. I mean, this is all a part of the discussion today, which I didn't have time to talk. But we do a pre-surgical ultrasound scan. So there is a pre-surgical anatomical mapping because you can have an velamentous cord insertion in the lower segment, especially at the place where I'm going to make a skin incision and an incision on the lower uterine segment. So the very pregnancy and the very blood vessel that I have protected for 8 months, I will incise at the time of cesarean section if I don't know where the vessel is and where the cord insertion is. So we map the vessels where they are on the lower segment, and we try and make sure that the entry for delivery of the baby is avascular in elective deliveries. In emergency deliveries, if somebody comes with an APH, you have to do the best you can and deliver them straight away, and fingers crossed, hope for the best. But the whole essence of prenatal diagnosis of vasa previa is elective delivery to avoid that very scenario of emergency delivery, and therefore we deliver them at 35 with the small risk of iatrogenic preterm birth at the expense of avoiding the very outcome of emergency delivery and losing that pregnancy.
Do you put them in hospital?
No. A lot of people, yes, a lot of people in the US do that, but we manage them as outpatient. Over the last 10 years, we have been screening for 10 years now. I have only admitted 2 patients, and those were because there was a progressive shortening of the cervical length from 29 to 25 to 22 to 18, and that woman stayed in the hospital because of a progressive shortening of the cervix. So when we scan them every 2 weeks, we monitor the cervical length, and if the cervix is more than 25, we send them home.
Thank you very much.
Thank you, Dr. Regent. We have a problem with the time, I think. Our next speaker will be Dr. Servidia Sankla. Our next speaker, Dr. Servidia Sankarna. She is a consultant of Fetomaternal medicine. Her talk will be about advanced diagnostic technique in fetal medicine. Please, Dr. Sankarna.
Thank you all for patiently waiting in the afternoon session. Just going to talk on advances in fetal medicine, but it's very hard to know what is an advance because what is advanced today becomes a story of past. So when I finish, some of it would have become very much integrated into our practice. So I think, we know that starting from our demography, lots are changing. For example, increased maternal age, increased artificially reproductive pregnancies. So there's a patient population and demography is changing. And now we can't do antenatal care without obstetric ultrasound. But we are moving on from screening and diagnosis to delivering precision medicine, and we are trying to optimize pregnancy and fetal outcomes through our diagnosis and further management. And that's where, I have a little problem when people talk hours and hours about screening and diagnosis, but if it is not followed by appropriate intervention, then you may not achieve the outcome. Like, for example, we talked about the vasa previa. If it is followed by timely delivery, that's when you will get the best outcome. And now we are, last decade, I think when I was applying for my consultant job, they said, what do you see as the future? And that was the days when we were trying to predict everything. But now we are moving on to prevention. And I think preeclampsia is one success story where we have moved on to prevention. And parallel around us, the world is changing. The TikTok has come, social media has come, and the bioengineering, lots of our advances are not happening in the hospital. They are happening in the bioengineering labs and by the lots of people who are contributing to advances are not doctors. They are engineers and various other support staff. And the medicine itself, fetal medicine was at forefront compared to other subspecialties in women's health. But now, everyone is ambitious. Everyone is achieving a lot. Success of uterine transplant and automation, robotic surgery. So we can't be left behind with all this, and we have to do this constant catch-up. And it is not something new to us. If you remember, just more than 50 years ago, obstetric ultrasound even came into practice. And in the last 50 years, thanks to all our pioneers and forefathers in this specialty, every year we have come across something groundbreaking that changes our practice. And I'm just going to sort of split them into imaging innovations and genomics, and I'm going to touch upon some emerging fetal therapy and evidence base. So I think these are the pictures of my first very car I drove in India, and this car on the right side is the one car I drove lost, and that has been replaced now. And the same with the ultrasound machine. The one on the left side is the one where I started learning to scan, and the one on the right side. And yesterday we had a demo from, I can see the Samsung, and I'm not advertising them, but they came for their new demo with lots of features of AI in it. So with that, the possibilities are becoming endless. It is the same way. For me, I just get into my car, switch it on, and drive until, some car nerd like my husband comes and show me, did you try this one? Did you try this feature in your car? Did you try that? So there is a lot more possible with our machines than we have the time to try. So there are 4D and stick. The fetal cardiologists have embraced it, and now fetal neurosonography, early anomaly scan. We have started doing that. It can make our job easier as we are becoming more and more interested in looking at those things. And of course, there was this presentation by Mindray this afternoon with the handheld ultrasound probe, which is making waves in the low and middle income countries where it's not possible for every clinic to have the more sophisticated, bigger machines that we have in our clinics. And I think COVID was a boon in terms of us clinicians getting to grips with virtual clinics and tele-ultrasound, which was like a novelty for us before COVID, whereas now it is like very easy. So you can guide someone scanning in the remote with your expertise using tele-ultrasound, and there are cloud-based images, which make storing and sharing the images very easy. And there are more nuances like ultrasound flow viewer visualization, if one knows how to use it. And there is Oxford unit is working on intelligent imaging in fetal health. And one of that is biometry, automation in obstetrics and beyond, which has become an integral part of all our new ultrasound machines. And then there is also, if you are interested in research, there are newer platforms emerging. And I think, we have been talking a lot about AI today, AI-assisted anomaly detection. I think both of these are from the institutes that I work in, from my fellow counterparts in fetal imaging teams, which has shown that, there is significant time saving. And, we all are prone for human errors. At the beginning of the clinic, I'm bright and bushy-eyed, and then towards the end of my clinic, my energy levels slump, and mistakes can happen. Whereas with the machine, it is programmed in such a way that cognitive overload is less of a problem. And also, our fetal cardiology has tried it with remote second review to improve detection rates. And we do that with our outreach clinics. So we are asking people to send images rather than asking the women to come. Sometimes even just to say whether they need to come or not. Of course, they're not very accurate, but at least you can filter a proportion of them where you can reassure them without having them to travel to you. And I think, I very much agree with what Professor Akalekar told about obs and gynae training. I know that in Spain and in some European countries, you have 6 months of obstetric ultrasound training as part of your obs and gynae. And as he said, if I had the power, I also would bring that in our training system. Because I think, just history and clinical examination can be extended to the imaging. And I think, without that, diagnosis is not possible either in obstetrics or gynecology. And it helps in rapid assessment. Lots of the time, my fetal medicine and obstetric ultrasound skills are very handy in labor ward, even to the postpartum, even for some women with a postoperative distension. So I would encourage everyone to, improve your ultrasound scanning skills. And I think, that would help your obs and gynae practice much better. And if this is accessible, but of course, if you have a problem, you also should have an expert to confirm. So always this has to be done with a formal ultrasound support in the backup. And of course, I'm not going to tell you about the details of fetal MRI, which will be explained in detail by Dr. Lisa Story. But I think fetal MRI has become an integral part of the fetal medicine practice, where it is complementary. It is not that it's not going to replace fetal ultrasound. I think both fetal ultrasound and MRI are going to help each other in coming to precision diagnosis and planning management. So there are lots of images, beautiful images there. So I think with that, as fetal medicine people, we have the responsibility to pick up the problems and to alert the neonatal team, alert everyone around us. We are the ones who convert the label from a low risk to a high risk. And then we get the support from our genetics in a huge way. And we are not even debating NIPT for trisomies anymore. It has become a standard practice in most of the countries. And globally, it has led to 60% reduction in invasive procedures. But of course, now NIPT is being tested for other conditions like triploidy, Turner's, and sex chromosomal aneuploidy. Obviously, the more and more data we have, the results will be better. The reason it is more successful in Down syndrome is because of the prevalence. Any disease, if it is hugely prevalent, then it works better. But if it is a condition like 22q deletion, which is not that hugely prevalent, then you get lower negative predictive value. And that is why, like most private units now all over the world are offering this extended NIPT paneling. And then when results come as positive, then nobody knows how to counsel them. And then they are referred to the government hospitals and the NHS hospitals for us to pick up the pieces. So I would say don't ask for any testing if you don't know how to counsel for those results. I think in sickle cell, it is getting closer to 100%. And I think the SMART study looked at improving the NIPT for microdeletion, and it combined the AI with the SNP-based methodology, and that is showing to be promising. But still, we don't offer that in the NHS yet. And now it's being extended to cell-free DNA analysis using transcriptomes for screening of preeclampsia and IUGR, like how it revolutionized the screening for Down syndrome. This may be the case in the future. And the other thing is the cell-free RNA, which is again being looked at. And we are not too far away from a time when NIPT for whole genome is possible. So coming to the next generation sequencing, of course, we were all started with our PCR and karyotype, and now we moved to microarray, SNP array, and now whole exome sequencing, who should be, and it all, if we have the resources, we would send all the abnormalities for whole exome sequencing because it targets the exons, the coding regions, but it's only 1% of the whole genome, but it's more precise in identifying single nucleotide variant defects. It's cost effective, and as we have experience and the volume improves, we are getting better results. For the best results, we have to have trio whole exome sequencing, and confirmation has to be done by Sanger sequencing. But it also has opened up to quite a lot of ethical dilemmas, some of which we will discuss later. And as I said, whole exome sequencing on cell-free DNA is in very near future. So whole genome sequencing looks at 100% of the genome rather than the 1% of the whole exome sequencing. It offers 11% additional abnormalities over what our traditional array and whole exome sequencing will provide. So moving on to single gene disorder panel, we did discuss about the cystic kidney panel, holoprosencephaly panel, which helps to screen for multiple genes responsible for a particular condition, which has helped in preconception counseling for future pregnancies. Right now, there is a generation study in UK that's ongoing where all women delivering in the NHS are offered the blood test for their newborn baby to screen for nearly 200%, 200 plus conditions. So they are chosen on 4 principles. These conditions should have severe consequences, and if identified, something can be done to correct them. So we are eagerly looking to the results of this, which will conclude in 2027. And the uptake among pregnant women has been brilliant for this study. So just to touch upon with some situations that we have come across. So we looked after a couple, their first child died of a neurological condition in the first year. In the first pregnancy, and that was quite a long time ago. And that time they identified as a pathogenic variant, and it was they were convinced, the geneticists were convinced that that was responsible for the condition. But as it happens with Oxford Dictionary, every year some words are added, some words are removed. In genes also this happens. What is OOS, which is the variant of unknown significance, becomes a pathogenic variant, and the pathogenic variant gets downgraded. So this particular condition was downgraded, and in the meanwhile, so she had a pregnancy in between, was tested, the baby had, and she had termination. So she came to us for the third pregnancy. Now this has been downgraded as a WOOS. So we took a lot of convincing for the lab to even do the test, and it came again positive for that particular variant. So now there was a big dilemma about whether we should be doing termination on this, because now it's downgraded, but the same, how do you explain, next time when you get normal results, can you reassure this couple or not? So we are going through the transformation stage, and hopefully in 5-10 years, we will have a much more definite answers for what is WOOS and what is not. So this was another condition. We had first trimester diagnosis of phallostetrology. She had CVS. SNP array didn't show any abnormalities. If you do SNP array, that rules out 22q deletion. So parents continued pregnancy, and then they had MRI. Our hospital has got a world-class MRI unit, so they get recruited for research and clinical studies. and so she had the fetal cardiac MRI in the 3rd trimester, and the coincidental finding was there was absent thymus gland, but we know it is not related to DiGeorge syndrome. So now do we offer whole exome sequencing? And she's around 34 weeks now. So we went more by common sense approach. Okay, is this going to make a difference to you? Because she's continuing her pregnancy knowing the baby has got phallostatology. What is the chance of us finding another genetic problem on a whole exome sequencing? And is it going to change your decision? So we had a frank discussion with the mother. And then there was only 6 weeks. Sometimes we may not get the results within that 6 weeks. So on a balance, the mother decided to continue the pregnancy and to test after the baby was born. But these are the situations that we as clinicians are going through the dilemmas as well. So just to quickly go through, the other thing is that, with all this genomic diagnosis one side, the other side is, in fetal medicine, when I went into fetal medicine, I thought I am a doctor for the fetus. But actually the reality struck me after a few years of fetal medicine practice. Actually, when I find a problem with the baby, I'm only terminating, I'm not treating them, which doesn't happen with any other branch in medicine. But it is quite encouraging to see that now the fetal therapies are emerging. I think one of our colleagues, Dr. Shangaris, he's working in King's, and he has done quite a lot of work on stem cell therapy, and it's quite exciting that it is actually becoming a reality in the near future. So the stem cell therapy is replacing the host cell with defect with the donor cell. The advantage of doing it in utero is the immunological system is very immature, so it is more tolerant than when your body has had opportunity to develop immunological reactions to foreign bodies. So it's very attractive to do it in the fetal life. So at the moment, animal studies are going, and it will very soon happen. There are lots of conditions. You can see the list of conditions for which stem cell therapy is possible in postnatal. So once it becomes, at the moment it's under the research setting, so this is possible. And it has got long-term health impact. Even though they are expensive in short term, in long term, there is a cost saving there. So the gene editing is the next step. As you can see with the stem cell therapy, the problem is the graft versus host rejections in 12 to 14%. It's not as high as postnatal. So that can be overcome with the gene therapy and even more precise therapy with gene editing. It's being a 15-year trial in pediatric population is ongoing. And if it is promising, this will be extended to the prenatal as well. So I think, I said fetal surgery because 20 years back when I was considering a career in fetal medicine, it was the fetal surgery was the most attractive bit for all of us to enter the fetal medicine. But then you realize that only 1 or 2% of the fetal medicine is fetal surgery. And we know the MOMS trial came nearly 15 years ago, but since then it has changed so much in the way it is being practiced in the whole world. Initially it was open surgery, whereas now it's more hybrid and fetoscopic surgery. And this is the latest one which looked at the practice all over the world. So I think we are going to get more and more evidence based so that we can counsel the women more definitively rather than based on one single trial which was being criticized for bias and practice. And we are pushing the envelope, and why wait until the baby is born? Can we do it prenatally so as to improve the outcome? So there are a few conditions where fetal therapy has surgical treatments have been tried, but they were all a few cases, and every case is unique, so it's hard to get a gauge of whether in utero intervention is more beneficial or more harmful in terms of pregnancy loss and prematurity. I think, the other thing is we have become more integrated with maternal medicine, and especially, with preeclampsia screening, placenta accreta. So we are working in collaboration with other colleagues in Obs and Gynae. Initially, fetal medicine was in the dark rooms of the ultrasound. And lots of the decision making in obstetrics is dependent on fetal medicine practices, and with truffle 2 trial is we are awaiting about the cerebroplacental ratio, and we already had the answer from the truffle 1 trial for the early onset IUGR. And so it's quite a lot that I feel I am an extended pediatrician rather than an obstetrician, because I'm looking after the same baby and then I communicate with my neonatal team. So it's my responsibility to make sure that transition happens smoothly. So I think our fetal care is extending beyond ultrasound scan rooms, and early diagnosis optimizes outcome and offers option, as was discussed in other topics today. And we are moving towards precision medicine rather than suspecting everything. And automation, research, and collaboration become overemphasized. And of course, we should not forget the ethics and the woman in the center of everything. Training guidelines, audit, and outcome measures are important for governance as we go through the transition to have some regularity. And of course, we are all global village, I never imagined I would be talking to you in Jordan. Travel, social media, internet, cloud, wireless, there are endless possibilities. Let's make the most of it. Let's learn to live with AI. Somebody asked me, I heard this quote that AI cannot replace our jobs, but we can be replaced if we don't work with AI. So I think it's time for us all to know how it is going to impact our work and how we can get the most out of it so that we are not slave to it and we are the master of it. With that, I would say a huge thank you for the chance to be here and to discuss with you.
Thank you, Dr. Sankran, for this comprehensive talk. There is a time for a couple of questions, if there is a questions. Dr. Falah.
Transfer embryos where you think they are gene-free from where you transferred, and you end up seeing that the patient has the same gene problem later on. Do you thinking of possibly allele drop out, probably getting pregnant from natural intercourse, and probably mosaic? And how would you deal with these cases if you have it? You tried and you thought you did, and you end up with something else. How would you deal with it? And most of the cases in the court, they are similar cases, How would you deal with it, and what are the possible problems dealing with these cases?
Yeah.
Medico-legal problems.
I think, pre-implantation genetic diagnosis and pre-implantation genetic screening for aneuploidies, now they are offering extended genes. I think, for aneuploidy, I would take the results of the pre-implantation, the IVF test results. For everything else, I would approach it fresh with the knowledge and the experience that we have with for other microdeletions. I think, over the next 5 years, 10 years, those, the pre-implantation genetic diagnosis could include all the screening for, the whole exome sequencing, whole genome sequencing would come even in the pre-implantation screening. But right now, I think I always find ourselves as the generation straddling between the paper and the digital, and we are the ones going through the transformation. We have to bear with the pain of learning as things change, but it will settle down in 5 years' time, so we know what is reliable from the pre-implantation testing. I hope I have answered your question.
I have a question.
Yeah, I think that is true. Gene editing, genetic engineering is possible. What we were told once upon a time as designer babies is a reality.
Beautiful talk. I have a question for you. Thank you so much for an update. Gene therapy. I didn't get that. What is it in, because also there's metabolic disorders that we can treat in utero, like other Pompe disease, cardiomyopathies with metabolic disorders. But I'm interested in gene therapy. What is it and which ones and what's the ethics of that? Thank you.
Yeah, I think I'm not an expert, but from having spoken to the experts on this, right now, like the drug trials, they are mainly at the animal studies. And I think for alpha thalassemia, it has come into the human one. For the rest of them, it is still in the trial stage. If anybody else has any update on that, I would be happy to hear.
I think gene problem, it is a big problem, especially in our area. We have patient, you can't believe, I have patient with 6, 8 deletion. And there is a clinical presentation, this family. This is a big problem. But what is good? The good is we have today these method of screening, and we are developing in every country this method of screening, whole exome, whole genome, to improve our diagnosis and to find if there is a method of treatment, at least to prevent them. I think the good medicine is preventive medicine. And the future of a preventive medicine, it is a fetal medicine. This is words of Professor Nicolaides, it's not my words. Because when we make diagnosis and we treat or prevent or even terminate pregnancy, we will prevent major problem. I have a patient who can imagine 10 years ago we can make diagnosis of myocarditis intrauterine. I have patient 18 weeks diagnosed with myocarditis because there is a gene specific for this such pathology. So we hope we improving with the time. Thank you, Dr. Sek.
Thank you.
Our next speaker, Dr. George Haddad, is a consultant in fetomaternal medicine. His talk is about management of polyhydramnios. Please, Dr. Haddad.
Take it off this, please. Just to put my laptop, I can answer the question just before. For example, in gene therapy, you have infantile spinal atrophy, due to the deletion of SMN gene. Now we have the therapy because there is a problem in this gene, but all nervous cells are not divided. So if we do gene therapy on the fetus, when he finished or on a newborn, he will be it's the therapy because the cells will not change. So we put this gene in every cells in neurologic tube, and that's it. Now actually we do it in postnatal, but for future it could be in antenatal. Okay, just one injection. So I think everybody. So really a huge thanks to permit me to speak about polyhydramnios. I think that all of you have at least 3, 4, 5 cases of polyhydramnios every year, and every time you can ask what to do. So I'll try to discuss with you what to do when you have polyhydramnios. As you know, amniotic fluid is something dynamic in prenatal. We have about 500 milliliters at 22 weeks. It goes up till 1 liter at 32 weeks, and then at the end of pregnancy, about 41 weeks, we have less amniotic fluid because we have about 500 milliliters. As we explained to you this morning when we spoke about uropathy and nephropathy, before 20 weeks, the amniotic fluid volume is equal to fetal volume, and it is an ultrafiltrate of fetal serum. It means that it's secreted by fetal skin, by annexes, by the amnion and the chorion. There is a very low contribution of diuresis and pulmonary secretion, and a very modest contribution of swallowing resorption. This is why if you have a kidney agenesis before 22 weeks, sometimes you don't have a lot of problem in the amniotic fluid because the contribution of diuresis is really very little. After 22 weeks, everything changed. The production of amniotic fluid is dominated by the fetal diuresis, by the pulmonary secretion, about 20 to 30% of amniotic fluid, and the resorption is not by placenta and chorion, but by swallowing. There is a really emergent role of annex and the membrane. So what's the role of amniotic fluid? It's a mechanical role, expansion of the uterine cavity, extension of the thoracic, and maturation of the digestive mobility. And the protection, because as you know, amniotic fluid is bacteriostatic and also bactericidal. He gave a thermal regulation, and he absorbed the hydraulic shocks. When we speak about polyhydramnios, it means that we have more than 2 liters of amniotic fluid. We have 2 kinds of polyhydramnios. The acute, it's more rare. It's between 1 on 1,500 to 1 on 6,000. It's usually in second trimester. It's one said brutal, and there is a huge intolerance of the mother. We can find it in TTS syndrome, as we explained this morning. It's quite often associated to polymer formation, to chromosomal anomalies, and very often it's a poor diagnosis. It's to compare to chronic polyhydramnios. It's really more and more, because it's between 0.2 to 2% of pregnancies. It's usually in third trimester or on the end of the second trimester. Usually diabetes is responsible. The isolation is very progressive, step by step, usually. It have a better prognosis, and usually, and sometimes in 30 to 60% of cases, we don't know the reason. What are the risks attached to polyhydramnios? In the fetal aspect, to have the increase of perinatal morbidity and mortality, especially if we have severe polyhydramnios, as you see here. If we have a severe one, we have more than 11% of risk of malformation and more risk of morbid mortality. We have more risk of chromosomal anomaly if it is an early polyhydramnios than late, and if severe. So if you have it early and severe, you have more than 10 to 15% of chromosomal anomalies or other anomalies, 10 to 15%. The obstetrical aspect, as you know, you have a risk of premature labor. I cannot, oh yeah, they have left me here. I have to touch my laptop because he will fail لأنه ترك لي هيدي تحتها. Okay, so it's easier to put it here. Excuse me, because I have to use my hands. So we have a risk of premature labor, dystocic presentation, especially a cord procedence, a retroplacental hemorrhage, a dynamic dystocia, and hemorrhage after delivery. All this, you know it very, very well. So when we have polyhydramnios, we have polyhydramnios where there is, when we have less absorption or more production. If we product more, then we have polyhydramnios. If we have less absorption, we have polyhydramnios. When we have less absorption, it's when we have disorder of swallowing, especially if it's a neurologic disorder. For example, he have a problem to have swallowing, so we have a polyhydramnios. If we have an intrinsic obstruction, like Chaos syndrome, high digestive, or like high digestive obstruction, or if we have extrinsic obstruction, like, for example, a tumor, as we can see, or a lymphangioma, cystic lymphangioma. If we have chromosomal anomalies, we have problem to swallowing, so this is why you have more amniotic fluid. And sometimes it is idiopathic, we don't know why there is less absorption. The production is when you have a fetal polyuria. When you have fetal polyuria, if you have hyperosmolarity, like maternal diabetes, like nephrologic disease, if you have an augmentation of the natriuretic factor, like anemia, alloimmunization, fetal heart failure, fetal maternal infection, and TTTS syndrome. And if you have an excess of non-urinary production, for example, if you have an anencephaly or a spina bifida, or if you have an arteriovenous shunt, you have more liquid coming not from the baby, but from this malformation, from the baby, but from malformation, and you have more and more amniotic fluid. So when you see a polyhydramnios, we have to transform your exam from a screening exam to a diagnosis exam. If you know to do an expert exam, no problem, you can do it yourself. But if you don't know, you have to ask someone who knows, who is expert, who knows how to do diagnosis and to see this. In France, it's easier for us. We have done, since 2010, some recommendation for diagnosis exam. And there is a paper, paper number 8, because we have about 15, in every situation what to do. And the paper number 8 is saying, if you have an amniotic fluid index, fill-in index, more than 20 centimeters, or more than 25 centimeters, excuse me, and if you have a SDP, a single deepest pocket, more than 8 centimeters, in this situation, you have to do what the recommendation number 8 will ask you. And what is written in this recommendation? It tells you you have to see the maternal context, diabetes, dialysis, insipid diabetes, immunization, KEL or rhesus. You have to do biometry fetal to see if there is macrosomia or if there is an IUGR or small for gestational age. Looking for sign of polyuria, it means that if when the bladder is empty, you see when it's full. If it is less than 13 minutes, excuse me, if it's less than 13 minutes, it means that there is a huge polyuria on the baby. If you have a moderate urinary dilatation, you have to see if you have a sign of increased cardiac flow. For example, if you have a cardiomegaly, if you have tricuspid regurgitation, if you have a disorder of fetal heart rate, if you have an increase in the velocity peak of MCA, I will show you, it means there is an anemia, fetal anemia. Search for a shunt effect, excuse me, for shunt effect, if you have placental chorioangioma, if you have, excuse me, voilà. If you have a mediastinal deviation, if you have an abnormal pulmonary echogenicity, if you have an abnormal chest mass, I will show you all these images. Looking for sign of fetal mobility disorder, it means if you have an akinesia, an immobilism, or an absence of suction and swallowing. If you have a digestive tract anomaly, double bubble stomach image, small or absent stomach, intestinal dilatation, or looking for anomaly of the face, if you have Pierre-Robin syndrome, the position of the tongue, migrognathia, or if you have a cleft. How to confirm the polyhydramnios? First of all, you have a subjection appreciation. What is the subjection appreciation? Is if you can put an abdomen near another abdomen. As you see here, you have here an abdomen. I can put another one. You can say, oh, perhaps there is a hydramnios, like here or like here. But the semi-quantitative appreciation is, for example, to measure the amniotic fluid index. This is what Félon described in 1987. It's a long time ago. So you have to take the sum of the largest pocket measured in each of the 4 quadrants. You have to be strictly on anteroposterior and vertical measurement, and without any interposition of fetal structure or cord. And you speak about polyhydramnios is if you have more than 25 centimeters. You speak about mild polyhydramnios between 25 and 30, and a severe if it is more than 30. And actually, we use more and more the single deepest pocket. It's easier, especially in TTS syndrome, because you measure the deepest pocket. You have to be always strictly anteroposterior and vertical measurement without any interposition of fetal or cord structure. And you speak about polyhydramnios if it's more than 8 centimeters, moderate between 10 and 15, and severe if more than 15 centimeters. So you have to do biometry and you have to do morphologic assessment. So first of all, as I explained to you, you have to search for the reason. Obstruction of the digestive tract. As you know now, with our new machine, we can see the esophagus. As you see here, trachea, esophagus, and aorta. And in dynamic exam, you can see swallowing when there is passage of amniotic fluid from the mouth to the stomach. Okay? So if you don't see the stomach, if you don't see on measurement of abdominal circumference, you have to search for is Putsch sign. The Putsch sign is a cul-de-sac of esophagus. It's like the interruption of esophagus here. This is what we call Putsch sign. The Putsch sign is the sign of obstruction of digestive tract, and especially the type 1, there is no communication between esophagus and stomach. But unfortunately, the type 1 is not the most important. It's just 10%. The most important is this type 3 here. And you have a communication between trachea and stomach. So the stomach is not, it's just very thin. He's not empty, but there is some secretion inside coming from the trachea, but you have the Putsch sign of esophagus, and you can confirm that there is an obstruction of digestive tract. If you have this, you have to search also of Vactal syndrome and to see here the vertebral, here and here, and also the anus and the radius, etc., to see if there is other malformation, if there is a vector sequencing. The obstruction can be lower, as you see here on stomach. When can we speak about double bubble? When the other image, liquid image, this is stomach, and this is the duodenoma. And look, always when you have double image, the second image have to be on the second half of the abdomen. It means you take you put a right from here to here, and you have the image on the second half of the abdomen. And you see like here, and there is a contraction of stomach, but it stopped here. Look in color what it gives. The amniotic is blue. He's coming from the stomach to the duodenum, and because there is a stenosis here, hop, they're returning in stomach. This will be a duodenal stomach. The obstruction could be also less high here in intestinal colon, and here also. Yeah. In the bowel, excuse me. You can see it in the bowel as we see the two. You can also have diaphragmatic hernia. You can also have a problem with the thyroid, as here goiter. You see here the trachea, and there is a compression on the trachea and on the esophagus. And like you see here, you can see a lymphangioma with here the trachea, but there is a compression on the esophagus. Here we have compression. As you see, look here, the aorta is very compressed because we have here a CCCM, a congenital cystic adenomatous malformation. Here you have a pleural effusion, and here, as Ala showed you this morning, an hypoplasia of thorax. You see here what we call in France the champagne sign. It means there is when you open a bottle of champagne, you see it have this form. You see, tuck, and we say champagne. And especially, you see that there is the index, the cardiothoracic index is high. It's not because we have a huge heart, but because we have a little thorax. And if you put the thorax and the abdomen on the same image, you have the thorax very little than the abdomen. The heart failure, for example, here you have fetal tachycardia, supraventricular tachycardia, and you see that you have ascites, but you have also polyhydramnios. As you see here, you have a huge heart, a cardiomegaly. It's more than the cardiothoracic index is more than 70%, and you have here tricuspid regurgitation, as you see here in blue, coming from from right ventricle to right atrium. The fetal anemia, you see, excuse me, you see the red cells in arteries are like cars on the highway. Less you have car and more the speed is important. If you have a radar on the highway and all cars are going just for 40 kilometers an hour, you say there is a lot of cars. If you have the speed more than 100 kilometers an hour, it means that you don't have a lot of car because people are going very, very quick. It's the same thing with red cells in MCA. In middle cerebral artery, if you have a huge speed, it means there is an anemia. How to calculate? It's very easy. If you are on 25 weeks gestational age, the speed have to be, the velocimetry have to be less than 50 centimeters, the double of the maternal age, gestational age, excuse me, gestational age. If you are on 30 weeks gestational age, the speed have to be, the velocimetry have to be less than 60 centimeters second. If it is 75 or 80, it means there is an anemia. So look here, we are on 26 weeks, we have, the velocimetry is 80 centimeters second, we have an anemia here in this situation. You can have arterious venous shunt, like here we have chorioangioma. In my center, we treat them. We have more than now 40 chorioangioma. We have embolized 40 chorioangioma. We have just one not success because we have, it's our fault because we took the vein and not the arteria, but you have to embolize the artery and not the vein. We have more than 40 cases. As you see here, we have sacrococcygeal teratoma with a huge vascularization, so this is why we have a huge shunt. Here we have a Gallia malformation, and in this situation, the heart will be there is a cardiomegaly, the cardiothoracic index will be very high. Fetal immobility, fetal immobility, I'll speak, I'll speak about this. As you see here, you have arthrogryposis, but especially look on this feet and on these legs. You have no muscles. Look on this. The muscles are very, 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 very thin. This is the bone and this is the muscle. This is anakinesia, and because he's not moving, there is no movement in the face, and this is why you have a polyhydramnios. Also, you can have a malformation, as you see here, there is no mandibula, or here the tongue, look here, the tongue is vertical, is going in the cleft, in the palate cleft, so you have a problem to swallowing, so this is why you have a polyhydramnios. This is an epulis, as you can see here. This is a tumor of the tongue. Okay, this is the node, and this is the tumor, and you can see the tumor just coming out from the mouth. Complicated monochorial pregnancies, as they explained to you this morning, you have here the stuck twin, and you have polyhydramnios for the receiver. Attention for PIL-fold, this is a false positive because this is a cyst of the gallbladder, and this is not amniotic fluid. And every time you have polyhydramnios, you have to measure the cervix, always, as you see here, because the menace of premature delivery. And to resume, if you have polyhydramnios, you have to do maternal biologic assessment to see if there is a diabetes, immunization, Clay-Hauer, all the serology, and especially CMV. If it is positive, you have to treat the cause, for example, diabetes, and you have to have a monitor clinically and ultrasound monitor. If it is negative, it could be idiopathic. If the amniotic fluid index is less than 30 or the SPD is less than 12, we continue ultrasound monitoring. But if you have a confirmation of a malformation not found, it means it's idiopathic. But if you have more than 30 amniotic fluid index more than 30 or SPD more than 12, or if you find a malformation, in these two situations, you have to do amniocentesis. And if the amniocentesis find an anomaly, curable anomaly, or for example, a trisomy 16, for example, and normal karyotype, you have clinical and ultrasound monitoring. But if you have a severe fetal anomalies or abnormal karyotype, we can discuss termination of pregnancy. The treatment, if you have no reason, especially if it's idiopathic, is to have to do drainage. It's currently the most widely used treatment. We have to do it every 15 days. And the follow-up is with SDP or with amniotic fluid index. Never take more than 3 liters every time you do an amnio drainage, and the amnio drainage has to be very, very, very easy, very, very long, because you know if the pressure is going down, you have complication, or we can have a pre-labor rupture on membrane or a chorioamniotis. Sometimes we use endomethacin. I don't use it a lot because I think it's not very nice for the kidneys of the baby. But because it gives problem to the kidneys, there is less diuresis, and this is why there is less polyhydramnios. So we reserve this for TTTS syndrome and for Bartter syndrome, when it's very important polyhydramnios. So iterative amnio reduction, amnio drainage, regular ultrasound monitoring to see always the cervical ultrasound to prevent the premature birth. And someone for severe and recurrent early polyhydramnios, we can sometimes, very, very rare, discuss the pregnancy termination. So be very, very have attention to the risk of cord prolapses. This is why, and also retroplacental hematoma, due to sudden retraction of the uterus after emptying. This is why we use a drainage, a very smooth drainage. We have a risk of dynamic dystocia. So, in conclusion, the follow-up is with SDP or with amniotic fluid index. You have always to ask an expert when you have polyhydramnios, because you have to see everything. Always to search about macrosomia and careful morphologic evaluation according to the recommendation. In France we have number 8, but you can have your proper recommendation in Jordan. And you have a metformin will be guided by a reference ultrasound scan. Thank you very much.
Thank you, Dr. George. Any question for Dr. George? Okay, thank you very much. I don't know if we go to the next session or to the coffee break. 20 minutes coffee break, please.